Hello, I'm Yvette Torres. Thank you for joining us today as we talk about reducing discriminatory practices in clinical settings. The last people you might expect to display discrimination towards individuals with substance use disorder are healthcare professionals. We often think that healthcare providers are immune to stigmatizing beliefs and discriminatory practices. However, it's important to recognize that just like everybody else, they too are susceptible to stigma and prejudices. These negative feelings and beliefs may affect their attitudes, judgments, and delivery of care to patients in need of treatment. We already know that stigma acts as a barrier to individuals seeking needed treatment for substance use disorders, resulting in economic, social, and medical costs for communities throughout the nation. Stigma further contributes to the negative attitudes, beliefs, and behaviors of healthcare professionals towards people with substance use disorders. In today's webcast, we sit down with a group of top experts to discuss the nature and extent of discrimination in clinical settings, its origins, and perpetuating factors, and what we can do to take on the challenge of reducing discriminatory practices in healthcare settings. Today we are joined by Dr. Michael Beerer, Assistant Professor of Medicine at Harvard Medical School and physician at Massachusetts General Hospital. Dr. Beerer became the first clinician in the homeless clinic at Mass General as part of the Boston Healthcare for the Homeless program, and went on to lead the efforts for 13 years. He is boarded in internal medicine and in addiction medicine, and is an active member of the addiction consultation team at Mass General Substance Use Disorder Initiative. He serves as president of the Massachusetts Society of Addiction Medicine. Dr. John Kelly is the Elizabeth R. Spaulding Associate Professor of Psychiatry at Harvard Medical School, the first endowed professorship in addiction medicine at Harvard. At the Massachusetts General Hospital, Dr. Kelly serves as the director of the Recovery Research Institute, the program director of the Addiction Recovery Management Service, and the associate director of the Center for Addiction Medicine. His clinical and research work focuses on addiction treatment and the recovery process, mechanisms of behavior change, and stigma and discrimination towards individuals suffering from addiction. Dr. John Renner is a professor of psychiatry at the Boston University School of Medicine and associate chief of psychiatry at the Veterans Administration Boston Healthcare System, where he directs their outpatient addiction treatment program. He is the director of the joint Boston University VA Boston Addiction Psychiatry Residency and associate director of the Boston University Medical Center General Psychiatry Residency Program. Tom Coderre is the senior advisor to Rhode Island Governor Gina Raimondo, where he serves as a liaison to the General Assembly and coordinates the state's response to the opioid crisis. In 2014, he was appointed by President Obama as Chief of Staff and Senior Advisor to the Assistant Secretary for Substance Abuse and Mental Health Services Administration. Welcome to you all.
Thank
John,
you.
The last webcast we did and the one previous to that, we talked about many addiction issues, but for today's purposes, we would like to review for our audience the definition of stigma and discriminatory practice. Can you do that?
Thanks, Yvette. Yeah. So a stigma, we can define stigma as an attribute, behavior, or condition that is socially discrediting. And it can take the form of self-stigma or interpersonal stigma in a social context, or it can also be institutionalized stigma, so structural stigma, which can occur at a much greater scale in our society or other parts of our society. Discrimination, on the other hand, relates to the unfair treatment of people who have that stigmatized condition or disorder. In this case, of course, we're talking about substance use disorder and related conditions, which are probably, in many countries, if not most countries, one of the most stigmatized conditions in most societies.
Very good. And what are some, let's go now to the entire panel. What are some of the examples of discriminatory practices that patients or clients can experience in clinical center? Dr. Beer?
Where to begin? I think in my clinical life, there are a lot of pressures around patients and including patients' beliefs themselves about the stigma of being prescribed a medication to help with addiction. So we have kind of this deep-rooted belief that abstinence is better. It's the best, and anything else is a concession to an unfortunate reality that we'd rather not deal with. And so patients themselves feel stigmatized when they are using medications for mental health disorders, not just addiction, and their families and social supports can also be making that a difficult choice for patients to make.
So, John, there are different levels then where stigma and discrimination lie. Can you break this down? Is it at the individual level? Are there also some experiences within communities and then structural within institutions?
Mm-hmm. Yeah. So as I mentioned, there's kind of the self-stigma that Michael just described, Dr. Vera just described. People can internalize the stigma which is attributed to them, which is projected towards them from the interpersonal context of broader society and institutions. And in the case of medications, that can be the case. And certainly, more broadly with mental health issues and substance use disorders, these are very common.
Dr. Renner, we were talking about discriminatory practices in clinical settings. Have you been the subject of experiencing some of these? Have you witnessed some of your colleagues?
I think, unfortunately, when you work with people with addiction problems or substance use disorders, other things happen. Medical problems happen, psychiatric things happen, and you often have to refer them out to other parts of the medical system. And you often learn that you can't be sure how they're going to be received. They will often, if they're coming in with a real pain problem, the other physicians will ignore the pain or just assume that because they have a history of addiction, they're only there because they want more pain pills and the symptoms aren't real. And I think that when we work in a system, we eventually learn who the doctors are that we can safely refer to and often who the doctors are that we have to avoid. And that's just a very real part of how we manage our clinical practice.
And Tom, you as a person in long-term recovery certainly have had your share of stigmatizing situations and the like.
Yeah, I mean, there are a lot of negative public attitudes that exist around addiction and recovery, for that matter. And as a person in long-term recovery, for me, it was very easy to be able to be public about my recovery story because my addiction was so public. I was a public figure when I went through my active addiction. I ended up getting arrested and had front-page news articles and news stories on the television about me. So it was an easy decision for me to be public about my recovery. But for a lot of people, once they get into recovery, they for a long time, they chose to keep it secret because they felt as though they could just take care of the problem, get back on with their lives, and everything would be fine. And what we realized is that was contributing to the negative public attitudes because then nobody knew anybody that was in recovery. So you've seen over the last 10 to 15 years, and thanks in great part to the work at SAMHSA, to really engage the recovery community to come out and be public about their stories. You see organizations like the NCADD or Faces and Voices of Recovery, now Facing Addiction, who's done big rallies on the National Mall and lots of public events where people in recovery come out and talk about their story. 25 million Americans live in recovery today. We need to hear from more of them.
This is very true. Are there, John, specific populations that experience more discrimination than others, or that are looked at with you know, a sort of closer eye within the addiction community?
Well, I think, you know, although we do talk about substance use disorder as a single entity, there is a broad spectrum, of course, of primary substances which people may use, and different levels of drug involvement and drug impairment which can affect behavior. So, you know, probably within the spectrum we've got the illicit drugs and we've got the illicit drugs, and then you have among the illicit drugs, some are more stigmatized than others. You know, you have the domesticated drug, alcohol, which is a legal drug, and we don't often think about it as a psychoactive drug, but of course it is. It's the most major contributor to addiction cases in this country and in most middle and high-income countries around the world. But we also, on the other end of the spectrum, we have illicit drugs, methamphetamine, crystal meth, crack cocaine, and heroin. So these tend to be the more stigmatized, marginalized, and more heavily stigmatized, and people who suffer from those conditions tend to suffer more discrimination. They tend to take longer and be more inhibited, even when they get into recovery, to disclose the fact that they've had those kinds of histories because of the continuing social stigma that we have around certain drugs. So you're absolutely right. It's not one entity, but rather even within this realm of substance use disorder, there are different levels of discrimination and
But
stigma.
have you seen a difference between, and I'm doing dare I digress?
You're allowed to do that. You're the boss.
But I do want to point to that. Is there a difference between those that use injected heroin or inject heroin versus those that are now coming into this new era of opioid overdoses, et cetera? Has there been a difference in the way that people look at it?
Yeah, and I think that, you know, this has to do with this idea of, you know, personal blame and fault. You know, the same was true of HIV. If you remember back in the AIDS crisis, you know, did you catch it through your own? Was it your fault, as it were? Did you engage in sex or you know, gay sex or
Unprotected,
injection,
yeah.
Unprotected sex? So, you know, was it your fault, or did you get it by a blood transfusion or something? So there was this different layers of stigma, right? Depending on and I think the same is true of. There's less stigma among, for example, people who became addicted to opioid pain medication after being prescribed pain med, as opposed to perhaps not going through that pathway but still ending up in the same place, that is using IV heroin. So yes, I think you're right. I think there are levels of different levels of discrimination.
And Dr. Beer, let's expand a little bit on that. Does it really depend, as John has, as Dr. Kelly has mentioned, in terms of the type of drug, and also whether a person or not is a person of color or not? Is there a difference?
So I think, first of all, it is not lost on me that you have 4 white male experts here at the table talking about discrimination and stigma. So we need to acknowledge ourselves that we exist in an atmosphere of implicit and intrinsic racism, and you know, it's the air we breathe, it's our upbringing, and we need to actively confront it. We need to sort of be in active recovery from our own implicit racism in order to do good work, in order to take care of patients well and respectfully and honorably. So, yeah, I mean, anyone in a stigmatized population in this country is going to face stigma at the hands of white men or others in the healthcare system. So, so yeah, that's a short answer. Yes.
I attended a conference in the fall that dealt with that exact issue. It was a collegiate recovery conference, and they were talking about how to expand in the diversity within the collegiate recovery community. And I was confronted by a young lady at the conference who really asked me to acknowledge my white privilege. She said, "I heard you tell your story. It's a wonderful story, but you know, you had access to things that most people don't have access to. the kinds of long-term treatment, psychiatric care, recovery housing, other kinds of services that everyone's not doesn't have access to, and as a result don't have the same opportunities and so I really that actually touched me in a way where now when I do give public presentations I mention that now because I think you're right. I think it's
You own
important,
up to it.
Dr. Berry. Yeah, no, and let's face it, this crisis was going on in communities of color long before it hit white suburbia. So we have to acknowledge that as well.
And Dr. Renner, let's talk a little bit about the veterans. Do they experience a lesser degree because they're vets, or what is their profile?
Well, I think people now have some sense that recent combat vets particularly are often stigmatized around the sense these guys have run amok in combat, or they're dangerous, or they're out of control, or they've seen terrible things and you never know when they're going to explode. So I think there are a lot of stereotypes that work in that direction. I think the sense of substance use problems is somewhat less visible. And I think there's another side of the racism issue, which is that if you are a white male, people may not even ask you the right questions to pick up whether or not the problem exists. So the problem may get ignored. So there's also that piece of how stigma may work out. I think the more positive thing for veterans are that they generally have access to a larger range of services. And the Veterans Administration has a pretty broad spectrum of services for most substance use problems, so that if they are identified, then it's relatively easy for them to get care, versus most people out in the community, where I think it's much more of a challenge. And particularly if you're not well-to-do and don't have the right insurance, it's extraordinarily difficult sometimes to get the care you need.
Very good. John, let's talk about healthcare professionals. Let's pull back to that. Why do these professionals, I'm not going to generalize, some healthcare professionals hold these stigmatizing and discriminatory views of individuals with a substance use disorder?
Well, I think as you alluded to at the beginning, Yvette, people, healthcare professionals are people too, and not everybody is working and is sensitized to every issue in healthcare. We tend to be kind of more specialized and sensitized to those issues that with which we work. And studies have found, for example, that healthcare professionals who are in psychiatry or in an allied profession that works with mental health and addiction have more favorable views and more positive views because they're more educated around these issues, understand the nature of these issues much more than perhaps other healthcare professionals who encounter people who, for example, in the emergency room might be intoxicated, they may be unpredictable in what they're going to do. And so when you don't understand and are not trained how to handle those kinds of problems in those contexts, then people become fearful. And they tend to stigmatize and don't know how to, and they act accordingly, just like the general public. Perhaps a little bit better, just because they are healthcare professionals. But I think those are some of the main reasons.
Yeah, I'd like to just chime in a little bit, because I think one of the differences in psychiatry is you have a better chance of seeing people in recovery, and the system is structured in such a way that you may be exposed to that. On the other hand, most medical people, their sense of this is developed in the emergency room. And medical schools actually are almost designed to show you the worst outcomes possible when people have substance use problems. And there's some data that suggests prejudice actually gets worse when people go through standard medical training. So I think we have a lot to do to change the exposure that occurs.
Why is that? Why does it get
Well,
worse?
because I think you see the people who don't recover, you see the people who are at the absolute worst point often in their career of substance use. And I think it's just reinforced that people don't get better, and it's like anything else. Yeah. That is real for some small percentage of the people that you may see in that setting. But as Tom was saying earlier, you never see the people in recovery. I mean, the people who are doing well don't come back to the emergency room. So they become invisible.
They don't end up on the front page of the paper either with their recovery stories frequently. But the person who just overdosed and died does. Yeah. That's on the news every single night. So you're absolutely right. It reinforces that.
So let me express gratitude to people who come out and tell their stories, and to you, and to the faces and voices, because it does make it easier for people to feel like there is a future, there is hope.
That's the whole point,
And
yeah,
Tom,
the hope.
I do want to really touch base, and we really haven't done it, and is really, as it relates to people in recovery who are under a regimen of medication-assisted therapies. Do you want to talk a little bit about that and clear
Sure.
the air
Yeah, well-
and really identify what some of the population feels about them and how what the reality is?
Well, Michael talked a little bit about it already, but just to piggyback off what he said, you know, it's interesting. So you have this societal stigma that John was talking about, and then, you know, as you get into the different layers, you have stigma within each of these layers. And when I say stigma, I'm talking about negative public attitude, I'm talking about shame, I'm talking about discrimination. And I think it's important to really define what we mean by stigma, because oftentimes we throw out the word stigma and we say people are stigmatized, but no one knows what that means. I mean, it means so many different things. There's so much packed into that powerful word, and I think we have to unpack it for people to let them know that means people don't get the care they need. It means that people don't get housing, they don't get jobs, they don't have the kind of educational opportunities that other people have. And so all the things that are predictors for somebody sustaining their life in recovery are not available to people who then are stigmatized. So that's really bad. Also, the people who are in recovery, who are sustaining their recovery through the use of medication, they need to be recognized as being in recovery. I mean, you are in recovery when you say you are. Whatever your pathway happens to be, if it happens to be medication, that's great. We have to recognize that people get to choose their path to recovery, and that we need to respect it and honor it.
Very good. And John, part of that has a lot to do with, and it's been mentioned briefly here, how the media portrays it. What role does the media play in terms of sustaining all these prejudices?
Again, how it's portrayed, as Tom mentioned, you know, it's what makes the front page is the drama, right? Is the drama disaster, and you know, people overdosing, crashing their car, all the things that you know, sensationalizes the problem, and that gets hits, it gets clicks, it gets hits, and of course there's a bias towards that from the media. So, but you know, to the extent that the media has or wants to have a public health impact and responsibility, then appropriately attending to the stories of recovery. You know, I've been at many different conferences and talked to many different groups of reporters to try and report very human stories of recovery. Yeah. And to depict human lives as with dignity and respect, that these are individuals who have suffered and are achieving a pathway to recovery, as was already pointed out, but also the language that we use. That is very important, and the media has done an increasingly better job, in my experience over the last 20 years, in reporting, and now the Associated Press have put out actually a guide for reporters to follow, which actually advises against stigmatizing terms. And this is because, in part, research has shown, and we've done studies here, to show that certain terms actually induce implicit cognitive biases against people with these conditions. For example, we did a study with healthcare professionals, roughly 700 healthcare professionals. I think John Renner was there at this particular event.
Yeah, but he did well, though.
He was
passed.
Maybe.
I remember John,
Just
Dr.
cue
Renner was there. But anyway, what was very interesting about this particular study that we did was that when people are exposed, what we found was when people are exposed, even top healthcare professionals in the addiction and mental health world, so this is their specialty, they're still susceptible to biases when they're exposed to certain terms, like calling someone a drug abuser, a substance abuser, as opposed to having someone with a substance use disorder. In fact, those people who were exposed to the term describing someone as a substance abuser were more likely to view that person as in need of punishment as opposed to treatment. Whereas people on the other side who were exposed to describing that exact same person as having a substance use disorder were more likely to view that person in need of treatment. So it does matter how we portray people and the language and terminology that we use to describe people who suffer from these conditions.
I love the study name too. The paper that you published talking about the study, "Stop Talking Dirty," right? It was the title of it, and I think that's really what this is all about. It's changing that language. I was at a forum last night in Rhode Island where Rhode Island PBS hosted an event with Blue Cross of Rhode Island on the opioid crisis, and Blue Cross handed out these little cards that they're now handing out at all their events that say we all have a role to play in Rhode Island's overdose epidemic. Help us change the conversation. And you open it up, and it's all say this, don't say this. So these are really important things that you're starting to see now get recognized by not only clinicians but health insurers.
But Tom, people in recovery themselves have to learn about language.
Oh, absolutely.
Can you want to just address that for a little bit?
Sure. We when I was at Faces and Voices of Recovery, we did some work around training people in recovery how to tell their stories. Most people who are in recovery get trained to tell their story in some type of therapeutic environment. So it's through their, whether it's their 12-step program or through group therapy or counseling, that's how they're used to telling their story. And they tell a lot of stuff about themselves as they would in a therapeutic environment. And that's not appropriate for language to use in the public. So our training is called Our Stories Have Power. It's a media and message training for recovery advocates, and it actually helps people in recovery talk about themselves, not as addicts and alcoholics, but as people in recovery, people in long-term recovery, and defining what that means. For me, that means I haven't used alcohol or drugs since May 15th of 2003. Last week, I celebrated 15 years in recovery, so major milestone.
Nice.
But it helps the general public then understand, oh, because the misperception is that if somebody's in recovery, they most closely associate the word recovery with a recovery room in a hospital. And somebody is not well when they're in a recovery room in a hospital. In fact, they're at their most critical stage. So we all think recovery is this wonderful thing. We wear purple. We celebrate it during the month of September. Thank you, Yvette Torres. But, but seriously, the general public, they hear the word recovery and they think of something entirely different. They think I'm about to, if they find out I'm in recovery from a substance use disorder, they think I'm about to get struck drunk or high, and that I'm going to be a risk, that I don't have any type of long-term commitment to my health, and those are things that are further from the truth. So we have to train people not to talk about themselves as their disease, but talk about themselves as their health and their well-being today.
And Tom, while I thank you, I want to thank SAMHSA and
Absolutely.
CSAT, the CSAT team that puts
For the
together
30-plus
recovery.
years of
Can
support
I
for recovery.
elaborate on that?
Yes, I was going to ask something, but
Because
go ahead.
well, just briefly, it's also the case that being a clinician, taking care of people who are working toward long-term recovery, it's work and it's hard,
Yeah.
and people aren't necessarily that secure or stable, we need to, as clinicians, celebrate, recalibrate our measurement of recovery and celebrate the baby steps as they occur. And my patient last week told me he did laundry and that he was leaving his apartment and was getting to meetings on his own. Those were huge steps for him.
Yeah.
So we were able to
That's a great point.
to celebrate.
And in addition to that, John, it's really, as we're getting more now into the area of how can we help providers to have a more compassionate view, as Tom was saying, if the client or the patient is feeling that shame, they're going to be down on themselves. So what are the cues for the healthcare providers? As Dr. Beer was noting, to really lift that person up and tell them, you are, I hate to go back to the African American, I am somebody, but you are a person who has an opportunity.
Well, of course, that's what we try to do as mental health and addiction specialists. We're always trying to do that, to communicate that and bring people up and help them feel, get a more accurate view of themselves and a positive view. But I think in general, I think first and foremost, we as healthcare professionals right across the spectrum of healthcare need to understand, try and remember, it can be hard at these times when someone's standing in front of you intoxicated and unpredictable, to try and remember to treat people with dignity and respect, but also be very mindful of safety, their safety and other people around them, because it's a fact that people who are intoxicated can be unpredictable and can be violent. This is a fact. And this is why, in part, that they're stigmatized. So recognizing that people deserve to be treated with dignity and respect, but also be very mindful of safety. So those things need to be conscious at all times, especially conscious, I think, when you're working in places where you're likely to encounter people who are under the influence, like in emergency rooms, for example. But then because people are in these settings where they're likely to encounter people who are under the influence, who have substance use disorder, to become more educated and trained around how to deal with individuals who are coming in. And I think it's happening. It's happening. There is a shift happening.
I see it
Unfortunately, because of the opioid crisis, that this has taken front stage now, addiction, thankfully, because opioids has really put it on the map. Of course, it's not just opioids, but it's placed it front and center in everybody's public life now and conversation, which has been a good thing as well as a very tragic thing.
Very good. Dr. Renner, let's continue along those lines and really talk about the compassion side. You know, how does a clinician, as Dr. Kelly has mentioned, keep that balance?
Well, I think it begins with your assumptions. And I learned a very long time ago that when I'm talking to someone who's really at the early stages of treatment or recovery, that I should assume that they're feeling depressed. I should assume they're feeling discouraged. I should assume they're feeling very shaky in terms of their self-esteem. And to me, that means I have to be extraordinarily careful with the language that I use. And not just the more obvious things, but I think the subtle things that may convey discrimination or hopelessness, or you have to be able to instill in people that they are worth something, that there's an optimism for them, that they have a future, that recovery is possible. And you should assume in the very beginning of treatment that they don't believe that, or that they may have very little internal capacity to provide that drive, if you will, towards recovery. And I think the clinician in the beginning of treatment has to really provide that for the patient. I think that's one of the most powerful things that you can do, that you can provide the self-esteem and the recognition that recovery is possible, and that they need to keep focused and trying again and not give up. And that's what I think you can provide to them.
I'll just add two words to your recovery is possible. For everyone.
Yeah.
For everyone. No, because it makes a big difference. Because if it's just possible, then it could be possible for me, but it could also not be possible. Yeah. And so when we say recovery is possible for everyone, we actually thought about this very carefully when we were releasing the Surgeon General's report on alcohol, drugs, and health, about using that terminology and being a little bit more hopeful. Even the way we talk about addiction being this chronic brain disease, you know, that this chronic relapsing brain disease is actually how we refer to it, and that doesn't sound terribly hopeful either. So when we did the Surgeon General's report, we talked about, sure, it's a chronic brain disease, but it has the potential for both reoccurrence and long-term recovery. So let people know that, yeah, you do have a disease, but you can get to the other side of it.
Yeah, and I think you need to understand that relapse is very likely to happen along the way, but it's very important for people to see that that's not an opportunity to give up, but it's an opportunity to learn, and that if you learn from your relapses, then you are able to move forward.
Sure, and as Michael was saying, it's about those baby steps that somebody makes along the way, right? That you celebrate those, because if your only definition of recovery is abstinence, there's a small sliver of people that are going to fit into that category, you know, and we know that there are people who are reducing harm to themselves and to their families and to society at large, and there's people who are on this pathway and doing really important good things that have a different definition of recovery.
if I just add one more thing. I don't want to put you out of a job. You've ignited something very special. No, but I just wanted to pick up on something that John and Tom and others have mentioned, is this notion of, the lived experience of role models in recovery. And one of the things that's innovative clinical models that is happening and catching fire really all over the country are recovery coaches. And these are peers or peer specialists. These are people in recovery who are now becoming part of clinical teams. And as Michael knows very well, Dr. Beer, sorry, both times.
That's right.
Should be mentioned, Dr. But this is catching on all over the country, this innovative model of recovery, who are peers in recovery, who have that lived experience. And as John said, when you have people with a lived experience, but who are a role model of being someone who's in recovery, that's very powerful for breaking down the stereotypes, to actually see, but many people have never actually seen someone who is in recovery.
That's right.
And so breaking down that stereotype, shattering those stereotypes can be very important for getting engagement, which is so hard to do, as John mentioned.
At that PBS event that I was at last night, there was a young man there by the name of Gary, who was one of those recovery coaches, and he was working in a treatment facility that it's actually a medication-assisted treatment facility, and he is on medication himself, and he's providing that hope for others who are going through that journey.
Can I again, sorry, but the other thing that working with recovery coaches does is it enhances compassion by really, in a very visceral way, teaching us providers that we are not different from our patients. We are our patients, and the separation is illusory. And when that becomes a reality that you really own and feel deeply, it's hard not to be a better clinician. It's hard not to respect more the people who you're trying to help.
Well, which brings us to the point, as we try and identify what clinicians can do to limit discriminatory practices, that perhaps creating a nucleus of recovery coaches to assist those that are recently entering the recovery process or that need to enter the recovery process. Would that be a correct statement? In order to get these clinical settings to be able to be more sensitive to their needs?
You
Yeah.
look like you had a...
I just wanted to add to that I think that one of the dangers that we have to acknowledge is you can't lecture this material to people. I think clinicians have to sort of live the clinical life where they're actually engaged with patients, seeing people in recovery, seeing people struggle, both relapsing and getting better. And I think that's the only way the message really will get through to them in a way that's really very real. I worry too much that we think we'll just run new courses and have lectures and that somehow is magically going to alter people's attitudes. And I think that's very difficult to do.
Well,
But I
we
think
can actually enter them and, include this subject matter in the residency programs, correct, John? Dr. Kelly?
Yeah. No, exactly. I mean, education is a piece of it. It's not the entire answer, because education does not translate into practice necessarily, of course. So it has to be with supervision and training and exposure and integration with people who are in recovery who suffer from these conditions. Yeah.
And to answer your question, to follow up, I think putting recovery coaches in clinical settings is really important. We've had tremendous success at putting recovery coaches in emergency departments in Rhode Island, especially in light of the overdose epidemic that we're in the middle of. And these recovery coaches, 50% of the people who have experienced an overdose and are in the emergency rooms in Rhode Island now see a recovery coach because it's an opt-in. They have to they ask the patient if they would like to see one. 50% of the people say yes, which is great. I think, there was a story written that said only 50% see them. I think that's amazing that 50% agree to see somebody because that person walks up to that bedside and say, you know what, I was in that bed a year ago, 2 years ago, 3 years ago, and here's what happened to me, and here's how I got to the other side. And they just have, a way about that, and it does it goes back to the clinicians who are watching this activity happen, and that does have an impact in changing attitudes in that emergency department too, to say, okay, we're not just seeing people who overdose all the time, we're actually seeing people who actually overdosed once, were in here as a patient, and now they're coming back as a recovery coach. So it does provide hope to those clinicians as well.
I agreed completely, but I want to sound a note of mild caution in that it's a very demanding job. It's a very
True.
emotionally fraught job, and I don't think we should say, okay, we'll just hire up a bunch of recovery coaches that'll fix stigma, and they'll take care of
No, it's a part of
people
it.
with addictions, and
Yeah.
we're off the hook. Thanks, recovery coaches. I feel like it's a very tough job in a high-risk environment, and we need to be supportive and cautious of our colleagues doing that work.
Really high compassion fatigue, right, in those positions. So we have to help people take care of themselves in those positions. But I think this is a multifaceted, multidimensional problem. It's going to require multifaceted, multidimensional solutions. Recovery coaches are but a piece of the puzzle. Yeah.
And Tom,
Yeah.
have you ever had a conversation with a clinician who came to you that you wanted to convince to have a different attitude and behavior towards those in recovery or in need of recovery? And how did that exchange go? And
Yeah, I can't think of one that's like really super stigmatizing or something that really hurt me in any way. But I do think back to when I was going through my own addiction, and I had presented to my primary care doctor that I was having problems with alcohol and other drugs, and he had no training. He had no referral sources. He did not know what to do with me. Ultimately, he referred me to a psychiatrist friend that he had, who also was not an addiction specialist, so didn't really have the tools that he needed either. And he worked with me and tried to help me, but I continued to have reoccurrence of my symptoms, relapses, frequent relapses. And he said to me one day, he goes, "You seem to be having problems at night and on the weekends." He said, "So we need to find a cage to lock you up in on the nights and weekends." That's what he said to me. And I was like, really, like an animal or something?
This is an example
And he's
of
like-
what not to do.
And he was well-meaning, but what he was talking about was treatment. But that's how he talked about it to me. And I didn't understand that, and I was fearful of that, and I resisted that, of course, as a result. But ultimately, as he explained to me, as he got me on the phone with the treatment center and talked to the clinician, and it became clear to me what it was, I became a little bit more willing to try it, and I did end up going into that treatment center eventually. It wasn't the last time I was in treatment, but it was an important moment of intervention.
And Dr. Kelly, even though I honor what Dr. Renner said in terms of the training issue being, excessive perhaps at times, but on this subject matter, but should not every single person that is providing health care be at least familiar with addiction issues? Because addiction is so pervasive in our society that in reality, when we talked, while I was at SAMHSA, we talked about the no wrong door. In order to have a no wrong door to addiction treatment, you really have to have individuals within the healthcare community be cognizant of how to be able to assess for it.
Mm-hmm. Yeah, and there has been a push. Joint Commission, for example, which is a big accrediting body nationally, requires screening for alcohol, for example. And it's not just addiction, okay? So we have to screen for substance use disorders when they don't meet for addiction. So on the mild end of the spectrum, as well as harmful and hazardous use, because we know that the use of alcohol, other drugs, will influence the efficacy and effectiveness of whatever else we try to do. And if we don't detect it, don't talk about it, don't ask about it, then we're not going to detect it, we're not going to account for it in our clinical paradigms and regimens. It's very, very important. You're absolutely right. It's the top public health problem in the country. It contributes a huge economic burden and also contributes to massive healthcare expenditure. So if we want to be smart about the way that we're treating health in general, then we need to be addressing substance use and substance use disorders and addiction.
And I'm glad you talked about legislative issues, because recently SAMHSA put out recommendations under the Women and Infant Act, and Dr. Beer, you are familiar a little bit with this, and you want to speak to that a little bit?
Well, I don't want, it would be a mistake to claim I'm familiar, but I know a little bit about some of the challenges that pregnant and parenting women face, and also a little bit about what is good clinical care in that situation. I can speak to that. Well, among the stigmatized populations in America, pregnant women who use drugs or alcohol or smoke may take the prize in terms of the anger that people feel, the blame they want to throw at them, as though they're making a choice to willfully injure an innocent. And I think there are a lot of states where this is criminalized, and where women are facing charges and who are losing agency and decision making about their bodies. And so to the extent that that can be undone through legislation, through court cases, that's a good thing.
Yeah. And encouraging women, I think, to go in for prenatal care, I think it's also very critical, because they can, adopt medication-assisted therapies that can help them pre and postpartum.
Yeah. So I'm maybe not making much sense, but if we look back at the cocaine epidemic, women were blamed, stigmatized. This notion of crack babies, and once you've done this to your baby, you've ruined the future for your offspring, was not true. It was a sort of a political blaming tactic, and we see that really women are feeling very guilty for anything they've done during pregnancy, and we need to support them in taking care of themselves as best they can.
Thank you. We're getting close towards the part of the panel that we need to entertain questions from our audience. So I'm going to give each one of you a last opportunity for you to give your final thoughts in terms of what you think is critical in order for us to continue to address this whole issue of diminishing the stigma and discrimination linked to substance use disorders. And I'll start with you.
Well, I think
Dr. Beer.
one place is to have a more diverse workforce in healthcare, and especially in the addictions field, just so that we can provide people who look like the people we're trying to take care of. And I think that's very important, and it's something we need to strive to do more of. And then this issue of kind of managing stigma part of the program that you're involved in as a clinician, and talking about stigma and making it part of the work that we do, I think it's empowering for us and hopefully for our patients.
Thank you. Dr. Kelly.
Yeah, I think I would just kind of amplify and state once again the idea of, is to remember your professionalism in a healthcare setting. So remember, in your training, and all of our training, and maybe from different disciplines, but to think about, every ethical code in every healthcare discipline talks about dignity and respect. And to remember dignity and respect when we're encountering patients whatever variety of patients and whatever disorder that we may be encountering, including substance use disorder. We know now more than ever the nature of how substances affect the brain, how they change the brain, how people's ability to control impulses, of course under the influence, but even when absent, to refrain from substance use, are dramatically impaired. We know this much better now than ever before in human history. We have a much clearer picture of the genetics that contribute to addiction. So we have good science now about the nature of these conditions, and so getting more education and training around that is a good thing overall for the number one public health problem. But I think most importantly to remember dignity and respect and safety.
Thank you. Dr. Wayne?
Yeah. I think from my perspective, the most critical thing is that physicians and clinicians in general are trained in a way that exposes them to people in recovery. And I think that means not just a week or 2 or 3 weeks in a treatment program, but that means in your clinic, in your medicine clinic, in your psychiatry clinic, in your OB clinic, you pick up patients who have substance use problems, have other problems that you would be treating normally, and you work with them for at least a year. And I think at the end of that time, what I've seen with our residents, you'll walk away from that enjoying the work. You'll actually have become convinced that treatment works, and you'll actually want to do it. People change dramatically, but it takes that long exposure. You have to see people in recovery, and you have to learn how to work with them over a period of time. So I think we have to retool our training programs to make sure that people are exposed to that kind of clinical experience.
And not give up.
And not give up. Right.
Thanks, Yvette. I'm going to shoot high. I'm going to say that we need to figure out a way to make addiction as integrated as possible in the general healthcare system. And I know that echoes upon some of the statements that have been already made, but there was a New York Times op-ed this weekend of a woman who told the story of going through 2 separate instances. Her brother-in-law had cancer and her daughter had addiction, and she mapped out the treatment options for each of them and how they were dealt with in the system. And the differences were dramatic. We need to bring addiction treatment, the standards of addiction treatment up so that it's seen as a real live disease, just like any other disease, and we need to pay for people to get the kinds of treatment that they need, the help they need to get better.
Thank you.
And also, and just to amplify, also the environment in which people are treated. If you look at environments where we would treat cancer, they look very different than the kinds of clinical environments in which we treat addiction.
Indeed.
That shouldn't be the case.
No.
If we want to engender dignity and respect among people who have often lost that sense of dignity and respect, we need an environment that is at least on par with other kinds of health.
Very good point, Dr. Kelly. And now we're going to go on to some of the questions from our audience. The first one is there any sensitivity training available for first responders? Interesting question.
I think the kinds of, I think yes, I think the answer is yes, and I think we're seeing first responders get involved a lot more in addiction treatment. I think mental health first aid is something that's been a popular item for first responders. A lot of police departments, fire departments, EMS are going through mental health first aid, which has a component about addiction, which is really super important. I think also in the opioid crisis and the overdose epidemic, I think the naloxone training and making naloxone available to every first responder and to members of the general public for that matter is really important. The Surgeon General just issued an advisory asking for everyone who can possibly carry naloxone to do it. So I think yes, and first responders have a huge role.
And I think within that also, they do get a sense of a little bit of a sensitivity training in terms of what's going on with
Absolutely.
that person and that needs to go into recovery.
Absolutely.
But two other points. One, there needs to be preparation for the trauma of seeing people dying and recovering and dying. And first responders do that anyway, but a lot of the general public who are now carrying
They don't,
naloxone are going to be traumatized.
True.
And we need to support them.
And I do want to mention that the Road to Recovery television show did a whole show on first responders. So that's available at the SAMHSA website. Next question is, I'm a medical student. What can I do to encourage my medical school to offer specialized addiction training in the curriculum beyond a handful of lectures? John. Kelly?
This person should get the Nobel Prize. Thank you. Whoever you are, medical student, thank you very much for asking that
Did you
question.
plant them? Are they one of your students?
They're not a plant. But what a great question, and in my opinion, a wonderful idea. I think we desperately need across the professions, including medical school, but across all helping professions, healthcare professions, to incorporate more formal education classes around addressing addiction and substance-related problems more globally, more generally, as I mentioned. So one of the things I think is write a letter. Not an email, not a conversation, but write a letter, mail the letter to the dean of your medical school, to other people in your medical, the provost of your university. Write a letter just detailing, doesn't have to be very long, in fact just one page, just detailing the significance and importance as you see it with genuine with genuineness. And I think that can be very powerful.
And ASAM, American Society for Addiction
Medicine.
Definitely has some training programs for physicians. I know that you've collaborated with SAMHSA to develop training programs at the medical school level and at different levels.
Right. I'd like to add to the advice that John gave the medical student, which is to your motivation to do this work may never be greater. Don't depend on senior doctors or faculty to do the work for you in terms of changing the curriculum. You need to do that. And I think perhaps gather people who have similar desires, who are like-minded, at your medical school, and develop a little committee and get vocal. So letters are important, but I think assume that mass action may have a different impact.
Is there a model they can point to?
So
a medical school that's doing this really well?
Well, so what's the Medical Student Association?
AMSA.
AMSA has been the vehicle that has helped students locally unite together. And for instance, in Massachusetts, there's a very vocal group of medical students at all the medical schools who basically demanded that and got legislation passed with some support from us older folk to get certain principles of basic care and medical approaches into the curriculum at every medical school.
I have one more question, and we can only have 1 or 30-second answers because we're at 57 minutes past the hour. How can addiction treatment be incorporated into prenatal care? What is the role of OBGYNs in linking pregnancy women to the appropriate resources, or women who are pregnant to the appropriate resources?
Yeah. I would say the fastest answer is get trained to prescribe buprenorphine, get the buprenorphine waiver. That's really the medication for opiate use disorder is really the state of the art for managing pregnant women as well as other people. And we don't have enough people who can prescribe.
And I have been reminded that SAMHSA does have guidelines for physicians to follow for treating women with an addiction issue for OBGYNs or when they're
So SAMHSA can be a good resource.
SAMHSA is a very good
Can I mention
resource.
one thing too? Following up on Dr. Brenner's comment, Brown University has added this to their medical school curriculum. So now anyone who's in medical school at Brown University has to become data waivered. They have to get their buprenorphine waiver. So they'll actually come out of medical school with it.
That's excellent. Dr. Renner, we have a question just for you. And it is, can you speak to the role of peer support and group therapy for veterans in order to destigmatize addiction treatment and encourage treatment seeking among veterans?
Well, I think peer support is particularly powerful. I think if you've worked with a group of veterans, you know that one of the things that happens in military service is this very intense bonding to the group. and they will look back on their years in the military as a crucial time in their life that is unlike anything else. And I think we need to maximize that experience because it's sitting there. And it's very easy to get the groups organized and people respond very quickly to each other. They share their common experience, both of being in the service, but also in this case struggling with an addiction. And I think they very quickly begin to support each other and help each other move along.
That's the last word. And that's all the time we have for today. A big thank you to our wonderful panelists, and a big thank you to all of our viewers who tuned in today as we discuss reducing discrimination in clinical settings. Please visit the SAMHSA website for more information on this webcast, including a taped version of the broadcast and resources that we discussed here today. Join us again for our final webcast in the series on Tuesday, June 19th at 2 p.m. Eastern Daylight Time, when we will talk about a future without discriminatory practices. We look forward to seeing you then.